Harry, who a lot of you know, who's currently working, if you understand, on the registrar training program, has worked here as a registrar as well. Fantastic guy, great doctor, and I'm sure in for a great speech. So, let's go there.
Thanks for having me. The title screen is the highlight of the talk. So what I wanted to talk about today was all of these terms, which get tossed around on Twitter a lot. But what does it all mean? You know, what is machine learning? What is deep learning? What is big data? And how does it apply to what we do? A couple of months ago, I gave a talk, kind of talking through the computer science of how it all worked for about half an hour, and it made the audience fall asleep. So I might skip that bit. And if you have any questions about how the algorithms in machine learning works, I'm happy to talk about it later. But basically, deep learning is the evolution of machine learning over time. And it's really in recent years, because of our advances in computer technology, that we've been able to harness it for healthcare purposes and pretty much any application in the professional sphere. So machine learning, unlike traditional programming, is a way of achieving an outcome without specifically programming something to carry out a task. It's using data to learn and achieve a set goal. And it's basically complicated math. I promised I wouldn't go into too much detail, but this is a basic example of one of the machine learning algorithms. It's called linear regression modeling. Anyone with basic understanding of statistics would know this. But in this example, if you knew the value of a really expensive house, and you put that data point on a graph, and you knew the value of a really cheap house, then you'd be able to extrapolate a line of best fit and predict what a moderately sized house would cost. And this is a very popular form of statistical modeling used by drug dealers across the world. So Mexican drug dealers in particular, they often send drones, and they have people on the border of America and Mexico keeping data of how many times there are border crossing guards that move at a certain point, and then they use linear regression analysis to figure out the best way to cross the border, which times of the year to do it, what their profit and loss will be. So it's very
smart, good.
Yeah, very sophisticated. Another simple way of explaining one of the algorithms used in machine learning is a decision tree. So in this example, as a App Store owner, you want to try and market applications to people depending on their age and gender. And this decision tree helps the program decide which way to market which apps to which people, looking at individual features. And you could use this in any scenarios. For example, if you're trying to differentiate between a cat and a dog, you could say, does it woof? Does it meow? Does it like you? Does it hate you? And get to the answer that you're looking for. You'd say yes, it's a cat at the end, or yes, it's a dog. And these are some of the buzzwords in terms of the algorithms used in machine learning. So linear regression, neural networks, support vectoring machines, Naive-Bayes algorithms. Deep learning, unlike machine learning, which depends heavily on individuals, experts in a field, from labeling lots of data, instead of doing that, you just pump a whole bunch of data into an algorithm and it spits out meaningful information. So the upside of deep learning is that it doesn't require really well-labeled data, but it does require a large volume of data. And we'll talk about how that influences its impact on its use in the healthcare setting. One of the common algorithms used in deep learning is something called a neural network. So you saw with linear regression analysis where you could plot a line of best fit through a set of data. With a neural network, you can use multiple inputs to achieve multiple outputs, just like a neuron. So you can have multiple inputs going into the neuron, and then there'll be an output, and they interact with one another in a convolutional neural network, backwards and forwards, creating new nodes and pumping out more data. I purposely didn't go into detail with this one because it's incredibly boring. So this is a traditional machine learning workflow. And as you can see here, in order for the machine learning algorithm to work, it requires someone to look at, so in this instance, using a machine learning algorithm to detect images, it requires someone to look at an image or a whole series of images, extract out the important features, for example, whiskers, spots, ears, noses, and then also label a set of data saying, this is a cat, this is a dog, this is a mouse, and then the machine learning algorithm learning that, and then after it's gone through that learning process, being fed the data that you actually wanted to analyze, and then it classifies it for you. And so really the classification is only as good as the data that you've labeled. And as I said, in the deep learning scenario, you don't need to do any of that. But what you do need is a large amount of data for the algorithm to analyze and for it to spit out its own outputs. So in this example, the deep learning algorithm is fed this image of a car. It breaks it down into individual pixels. It looks at each of those contours and it tries to put them all together into shapes it recognizes, and then it accurately predicts that this is indeed an Audi A7. It can also use, label data in natural language. So you can see the 6 images here. It's correctly labeled. There's a man in a black shirt playing a guitar. There's a young girl in a pink shirt swinging on a swing. So ways that humans expect to have data described to them. It can write books. This is actually a Harry Potter book that it's written. It can compose its own music. So it wasn't programmed on how to compose music. It's just sampled lots and lots of music that's been fed into it and it's made its own song. It can be used for data monitoring in traffic situations. So it can look at multiple vehicles passing through an area, multiple people passing through. It can recognize errors and problems before they occur. And this is what drives self-driving cars. So pretty much every manufacturer now has a self-driving car in the works. There are already retail products of the Tesla self-driving cars. Volvo have a Polestar. Audi and Mercedes all have them. It's only a matter of time before it becomes a day-to-day retail product. It can also be used for nefarious purposes. So this is I think this is in China, using to surveil people. And again, it's just in real time monitoring people's faces as they pass through an area and accurately detecting people of interest.
Oh, gosh.
This is a DARPA and Boston Dynamics project creating a robotic soldier. So what's amazing about this soldier is it hasn't been programmed to do any of this, but it's detected the obstacles, figured out how much force it needs to apply in each leg to climb up. I thought about changes in air pressure, wind direction, everything. And if you push it over, it can self-stabilize. This is Samsung's AI. This came out a couple of days ago, where they don't have a video, obviously, of the Mona Lisa moving around, but using that image and from the deep learning algorithm, understanding how humans move their face, turn their heads, move their neck, it's used that image to create a virtual Mona Lisa video.
We're entering an era in which our enemies can make it look like anyone is saying anything at any point in time.
Jordan Peele created this fake video of President Obama to demonstrate how easy it is to put words in someone else's mouth.
Moving forward, we need to be more vigilant with what we trust from you.
So it's not a real video and it's not real audio. It's all digitally reconstructed by a deep learning algorithm. And I'm sure all of you know the Google Duplex application. Does anyone know Google Duplex? Yeah, one person.
Can I hear you?
Hi, I'd like to reserve a table for Wednesday the 7th.
For 7 people? Can I hear you?
So basically, this is a artificial intelligence calling a shop on behalf of someone else to make a reservation. So I'll say that again. So, and you can see how it's interacting with a person where English isn't their first language, and despite not getting a clear set of audio data, it's still managing to have a decent conversation.
Can I hear you?
Hi, I'd like to reserve a table for Wednesday the 7th.
For 7 people?
It's for 4 people.
4 people when? Today?
Wednesday at 6 p.m.
Oh, actually, we need to for like after like 5 people. For people, you can come.
How long is the wait usually to be seated?
For when tomorrow or weekday or?
For next Wednesday, the 7th.
Oh no, it's not too busy. You can come for 4 people, okay?
Oh, I gotcha. Thanks.
And this is what kind of brought me into the whole AI thing. Watching IBM Watson play in Jeopardy, it absolutely creamed the competition, as you can see. And this is an example of it answering a question.
I will ask Luke. Even a broken one of these on your wall is right twice a day. Watson, what is clock? Clock is correct. And with that, you move up to 22,000.
So you can see on the bottom there how it's thinking about how to answer the question. It's weighing up the probabilities and coming out with the correct answer. And so, why haven't we had all this technology all this time? And the reason, firstly, is because of the lack of computing power. This is what 5 megabytes of RAM looked like in the 1960s. To put into context, I've got a 1 terabyte USB drive. It's about the same size as the tip of my little finger. So one is computing, just sheer computing power. And the second is the lack of highly digitized data, which is what's changed recently. And that's why every tech company and their dog are getting in the AI race. And the 2 main players in the health sphere are Google and IBM. And I'll show you what they're doing. So how can we apply deep learning to the healthcare space? So, obviously the thing that comes to mind straight away is in radiology. This famous radiologist in the 50s said, predicted the rise of computers taking over a lot of what they do. There was a ImageNet algorithm in 2014 that actually beat humans in telling the difference between a Chihuahua and a blueberry muffin, and galahs and smashed shadow and toast. And after that, someone thought, maybe if we got it to do the same thing that deep learning algorithms are doing for images, can we do the same thing for radiology images? So in the same way, the natural language processing is accurately said, there's no acute airspace disease, there's an ACL tear, there's a tumor at the gastroesophageal junction on the PET scan. But why bother? We've got perfectly good radiologists. Why can't we just continue to let humans do what radiologists have been doing for years? And it's because, well, first of all, there aren't enough radiologists. There's not enough healthcare professionals in every field. And humans make mistakes. But there's a difference between medical images and non-medical images. The medical images are really large, and the thing that you're looking for is often really small. The amount of data that is actually relevant to you is tiny. So unlike a cat filling up the majority of the photo, the changes that you'd see in a chest X-ray or an MRI scan or a CT are minuscule, and the amount of data you'd need for a deep learning algorithm to become good at doing what it does is immense. The other thing is, what is the ground truth, and what's the context for the image? So these are both MRI scans that look exactly the same, but the difference between the two is one patient is very young, and one patient is older than you'd expect these changes to be found. So one shows pathology, and the other is normal physiology. And that's why you need that context to make that correct diagnosis. The second thing is we often face these sort of scenarios when there are surgical clips, there's metallic artifacts, there's movement, there's breathing, and the machine struggles to understand images in that context, where humans would have ways of working around it. The other thing, what is the ground truth at the end of the day? What is the gold standard diagnosis is whatever humans called it before. So, is this a finding? Is that pneumonia, or would you call that atelectasis? Or is it consolidation? Is it just shadowing, or is it an actual medical diagnosis? It's very subjective. They ran this machine learning algorithm at one of the radiology conferences a couple of years ago, just looking at chest X-rays. And luckily, with that data set, it's much smaller, it's much easier to come up with an algorithm to look at those images. And this machine learning algorithm was at least as good as the radiologist at detecting pneumonia in a patient, at detecting pleural effusions, pulmonary nodules, pulmonary edema, diagnosing pulmonary emboli and fractures, DVTs, and acute infarcts in the brain. And in the cancer sphere, it's also been amazing. So before they had deep learning, they used the machine learning algorithm to look at CT scans, looking for lung nodules. And the sensitivity of that scan using, a less than accurate algorithm was still amazing. The sensitivity was almost 91%, and the specificity was 98%. And you can just imagine how accurate it's going to continue to get better with deep learning and better algorithms and more data. What's exciting to me is not just what machines can do that's similar to humans, but what they can do that's even better than a human can do. So what if you had a non-contrast image, but a machine could figure out what's important to you and digitally contrast enhance it for you, so you never need to give the patient contrast, and you can salvage the otherwise less than adequate image. And unlike a human, it doesn't need to look at the digitally reconstructed image. We get a lot of raw data, at the electron densities that you're actually measuring in the CT scan, without looking at the reconstructed image that a machine can look at that we can't. And again, who knows how much more information a machine could get from that. And the same goes for MRI. At the end of the day, you lose a lot of information with processing for humans. This is a leading AI practitioner in the UK who attended one of the British radiology conferences, and this is what he had to say about the radiology profession.
Let me start by just saying a few things that seem obvious. I think if you work as a radiologist, you're like the coyote that's already over the edge of the cliff, but hasn't yet looked down, so doesn't realise there's no ground underneath him. People should stop training radiologists now. It's just completely obvious that within 5 years, deep learning is going to be better than radiologists, because it's going to be able to get a lot more experience. It might be 10 years, but we've got plenty of radiologists already. I said this at a hospital, and it didn't go down too well.
The second obvious scenario, apart from medical imaging, digital imaging, is in the field of pathology. One of the major rate-limiting steps in starting cancer treatment is getting to a diagnosis. You need a pathological diagnosis, and sometimes it can take weeks. And again, the same sort of applications here. In this scenario, they used deep learning as an adjunct to a qualified pathologist to improve the accuracy and speed of detection of malignancy. They used a combination of machine and deep learning models, and you can see what the computer has detected accurately as the malignant focus within a tumor. And again, this is a combination of machine and deep learning from almost 6 years ago now, and its accuracy is approaching 99%. But again, what's exciting is not what it can do that's similar to humans, what it can do better than humans. So for years, well, up till very recently, and even currently, a lot of pathologists would ignore the stromal features, the extracellular features that we didn't think would be relevant for predicting a patient's outcome from cancer. But this machine learning algorithm looked at slides of patients that did well, who had breast cancer, and those that did poorly, and figured out not just cellular changes that the pathologist correctly identified as being higher risk for a poorer prognosis, but also identifying additional features, stromal features. So you can see how machine learning can expand our understanding of science. In the area of non-small cell lung cancer, particularly with adenocarcinomas, our traditional staging methods using the TNM staging doesn't really give us a great idea of a patient's prognosis. But again, by feeding the pathology data through this machine learning algorithm, it was able to accurately predict which patients were going to have a better prognosis than those that weren't, just using the microscopy. So this is Google's near retail product.
The mission is to increase the accuracy and availability of cancer diagnosis and save people's lives. I can hardly think of anything that's more motivating.
So you can see how in real time it's mapping out the tumor and assisting in at least making the pathologist's jobs easier and probably eventually taking over a lot of what they do. So what about radiation oncology? What about radiation therapy? What's a little bit disappointing is that the amount of research that's been put into radiology and pathology isn't the same as the amount that's been put into radiation oncology. We're getting much less. But I think that's probably going to change now that radiology-related research has become so mature. And there are multiple applications, but the main areas would be in target volume delineation, planning, and in QA. And why is this important? Well, because there's so much variation in voluming from one person to the next, from one day to the next, the same person doing the same plan again and again. There's going to be a huge amount of inter-operator and interdepartmental variation. And this study showed that, this is just looking at residents in radiation oncology volume the same periodic mass, and you can see the huge amount of variation there in volume supply. So this is from 2014 using a machine learning algorithm. And what they did was they got they randomized residents into either manually voluming the organs at risk on a head and neck plan, or getting a machine learning algorithm to do it, and then the resident to amend it, and then both data sets were checked by a consultant radiation oncologist. And this is a fairly small study, so it was 40 cases among the 8 residents. And what it found was, on average, the group that edited the volumes put on by the automated segmentation tool managed to do the task 8 minutes faster than the group that just volumed it from scratch. And what was also interesting was the accuracy in detecting, voluming the organ at risk was much better when you combined both the human and the machine learning algorithm. But it's not infallible, and you can see here that particularly when it came to the optic nerves and the optic chiasm, there was pretty poor matching to the consultant's final volume. But it's still better than if the registrar just did it on their own. This is from 2 years ago, and a completely different result, looking at planning a head and neck planning from scratch. And they compared a consultant in radiation oncology to the machine learning algorithm. The machine learning algorithm could do the whole plan in 12 to 13 minutes, volume the whole head and neck plan in 12 to 13 minutes. And overall, the final plan, they achieved a higher target volume dose of 0.6 and reduced the dose of the organs at risk by 2.4%. So not only did they do it faster, they managed to get a better result in terms of, probably will get a better result in terms of tumor control. You can see that the DVHs are fairly concordant for both the human and the machine, and those are the 2 volumes, top and bottom. Motion monitoring. So at Charles Gardner, I think CyberKnife already uses something similar to this, where when you're hitting a moving target, between the machine beaming on or moving to follow the target, there is a small delay by a couple of microseconds, and that makes a difference in uncertainty by about 1 millimeter, 1 to 2 millimeters. So this group, in addition to using the standard motion monitoring tools, added on a machine learning algorithm to predict the position of the tumor a few microseconds before the target reached that point. And because of that, they reduced their uncertainty by about 0.8 millimeters, by about 160 milliseconds, improving accuracy of targeting. And finally, quality assurance. So again, this is a large area of interest, and there's actually been quite a bit published in the American Association of Physicists in Medicine group, looking at QA practices using machine learning for routine QA on IMRT plans. And this first one was looking at predicted versus actual MLC positions and how that would affect a plan passing QA or not. And this machine learning algorithm could accurately predict which plans were likely going to fail QA, and applied its predicted MLC position into the plan and managed to get a higher QA pass rate as a result. This was the group that looked at virtual QAs on all IMRT plans. You know, we go through a rigorous QA process of all the IMRT plans, but basically what they found with this was that they were able to accurately predict which ones were likely to fail. You know, if anything, they under-predicted things. So you can imagine how this is going to help workflows. There was actually an editorial published this month by the president of the AAPM saying that, you know, the routine machine checks that we do, you know, the monthly QA, do we actually need to do it? And they ran a machine learning algorithm to predict which machines were going to have unusual output, and they could probably push out QA to 6 monthly, but I don't know if it's brave enough to actually do that. And finally, for the medical sphere, how does AI help clinical decision making? So DeepMind, as I said before, this is Google's AI algorithm tool. They're currently using it in the NHS, so they're using it to predict patients who have renal problems, predict which one of them are likely to require hospitalization in the next couple of weeks. But they're also specifically using it for segmentation of head and neck cancers. IBM's Watson is their competitor, and it has a much larger presence in the oncology space. This Japanese group ended up using Watson to accurately get a diagnosis that the humans couldn't get. IBM's Watson program is run out of Sloan Kettering, but it's also in a number of other cancer centers. And the video I'm about to show you is the experience of the head of department of UNC. He's talking about how he's changed his perspective on Watson.
Today. So we found that we were deciding on therapy based on information that was always, in some cases, 12, 24 months out of date.
However, it is a task that's elementary for Watson.
You know, they taught Watson to read medical literature essentially in about a week. It was not very hard. And then Watson read 25 million papers in about another week. And then it also scanned the web for clinical trials open at other centers. And all of a sudden, we had this complete list that was sort of everything one needed to know.
Did this blow your mind?
Oh, totally blew my mind.
We have the Watson recognition.
Watson was proving itself to be a quick study, but Dr. Sharpless needed further validation. He wanted to see if Watson could find the same genetic mutations that his team identified when they made treatment recommendations for cancer patients.
We did an analysis of 1,000 patients where the humans reading in the Watson report had doing the best that they could do, had made recommendations. So not at all hypothetical exercises. Real world patients where we really conveyed information that could give guide care. In 99% of those cases, Watson found the same thing that humans recommended. So that was encouraging.
That it encouraged your confidence in Watson?
Yeah, it was nice to see that. Well, it was also encouraged my confidence in the humans. But probably the more exciting part about it is in 30% of the patients, Watson found that they're new. And so that's 300 plus people where Watson identified a treatment that a well-meaning, hard-working group of physicians hadn't found. Because the trial had opened 2 weeks earlier, a paper came out in some journal no one had seen, a new therapy had become approved.
30% though.
We were very, that part was disconcerting because I thought it was going to be
disconcerting that the Watson found 30%.
These were real.
Yeah, so that's what's amazing. Not only is it near to humans when it comes to standard treatment plans, it's able to come up with new ideas that no one had ever thought of. This was presented at ASCO in 2016, and it looked at how long it took a doctor to analyze the pathology, imaging, the patient's notes before they saw the patient and come up with a management plan. It took about 20 minutes. for a registrar and about 12 minutes for a consultant. But it took Watson about 40 seconds to come to the same treatment plan. The other exciting area was its use in enrolling patients into clinical trials. So it was much better than humans at thinking about enrolling someone and actually going ahead and recommending them. So that's Watson Oncology, and ICON have a relationship with IBM Watson, and I think the medical oncology group are planning to or are already using this as part of their actual workflow for treatment recommendation. So what does this mean for us? This is in the AAPM, and this is what the president of our college said at Jeremy Croker's graduation ceremony when he became the president. He said, every technological breakthrough till now has resulted in more jobs for people like us. But artificial intelligence is probably going to result in less of us. And we have to be ready for that. So what are the potential scenarios? So number one, an artificial intelligence comes and replaces us. Which it's possible, but I don't see that happening for the next decade or two. But I don't know. I don't think it's going to happen in the near future, the relatively near future. What I think is more likely is this. Do you actually need, how long does it take to train a radiation therapist or a doctor or a medical physicist? It takes a long, long time. Do you really need to train a whole group of people that long to do this when you could get someone else who had an AI on their side to do maybe not the same, but similar? So that's that demonic creature there. So pretend that's that's a medical oncologist who's joined with artificial intelligence and taking over the job of a radiation oncologist. And this I also think is a potential outcome where instead of having as many of us, we could probably get by with less of us, double checking what an AI has already done. AI comes along, makes friends with one of us, and then eliminates the unnecessary fraction. But this is what's also exciting. There's a huge area of unmet need in our own country, but also around the world. And perhaps with the use of machine learning, we'll be able to meet that unmet need, and everyone will be happy. And that's it.
Wow, I'm scared. That's just a whisper to go. I'm glad that I'm quite old. Obviously, fantastic talk. Do we have any questions? From the audience? I definitely had one. You've presented lots of interesting sort of facts and stuff. What's your opinion on what will happen?
So all the machine learning guys, they say, it's 5 years away. But I don't know about you. Everything always seems 5 years away. So I don't actually believe that. On the other end, the American College of Radiologists say, this is never going to happen. This is just part of the hype curve, and everyone's really excited now, but it's nothing. I think the truth is probably somewhere in between. And I think the only thing really holding things back is probably bureaucracy and people's legitimate concerns about privacy. So DeepMind's actually going through a massive lawsuit in the UK at the moment for using a lot of patient data to construct their deep learning algorithm. On one hand, if you were the health minister, or if you were the head of a private healthcare facility, would you'd want to churn out more treatments, be able to do things faster, more accurately, not have to pay your employees. They will never sleep and never make an error. You've got to. There's an increase in demand for healthcare services, and that supply has to be met somehow. And I think this is probably what's going to happen. I think realistically, we're going to be working alongside AI in the next 5 to 10 years as part of our routine workflows. and there's probably going to need to be less demand for what we do. So certainly for a radiation oncologist, I think you'd be doing less segmentation than you are now, and you're probably focusing more on patient interface. If you're a proceduralist doing brachytherapy, you probably want to upskill and spend more time in theatre. As a radiation therapist, I think those that are in the planning room are probably going to be spending less time in the planning room and more time on the machines and more time interacting with patients, probably seeing patients in the clinic. And for the physicist, I think your QA demands are going to change. You're probably going to be doing less machine QA, and you may be doing a little bit more patient-specific QA or challenging circumstances where an algorithm can't do your work for you. So everyone would be affected.
I think as a manager in radiation oncology, in the public system, you've also got to think, as you said, about bureaucracy, and just that outlay, that cost outlay is going to be absolutely massive. I think there'd be obviously issues with coming to see a robo-doctor, so to speak. Patients are going to want, our patients don't even want to use our checking kiosks. They walk in, they've got a choice between a TV screen that says check in here or a receptionist, they ignore the kiosk. So there's little things like that. I think I've always, for the past year or so, thinking about stuff like this, looking at planning room, and like you said, is one issue. But it does depend on, like you said, how the boss of the organisation, be it the Minister of Health, be it the head of Genesis, ICON, anything like this, what kind of business model they want to run. I think this could give you the opportunity as a radiation therapist or as a radiation oncologist to, rather than produce a plan, a quite good plan, or a very good plan quickly for a patient and get more patients through. It's the multiple plans. It's the adaptive plan. It's once a week you head and next jump back on or they have a CBCT, and we produce another plan quickly. So every week it's that perfect plan for changes in contours, for changes in volumes. So there is, who knows where it's going to go. But I don't, I'm not saying this wasn't sounding a death knell for our profession or anyone's profession overall, apart from radiologists. My feeling has always been that it gives us opportunities to change the way we work. Not necessarily just everyone's got to think, shit, we're going to lose our jobs to the computers. It's working smarter. I don't think there's no other in here who wouldn't mind about not having to do so much manual voluming. Take that off your hands. You guys are not going to be too worried about that. It's well done. But that possibility of multiple plans during a patient's course of treatment is something that would be good and exciting development, and sort of a silver lining to what could be a cloud. So. My take on it.
And look, the other thing is, as healthcare workers, you're probably a little bit more insulated from the effect of machine learning than people outside. Machine learning will affect everyone across the spectrum, regardless of your profession. Every profession. If you're a lawyer, if you're a solicitor in particular, or if you're an accountant or a banker or anyone, it affects all of us, and it probably affects us a little bit less than those other professions. But the digital, routine, high-volume tasks that we do again and again, a machine's going to be able to do that better and more reliably. So yes, as you said, you'll have less mundane tasks to do and more exciting things.
So you can have more time off,
Maybe the demand for the psychiatrist meeting.
Guys, any questions or comments at all?
So Harry, you've got children. When they go to school and they go to start planning their careers, is there an area that you would direct them into where perhaps artificial intelligence isn't going to sort of take a hold?
So it's funny that you mentioned that. My daughter's 4. Granny's already got her stethoscope. So we asked her, she's only 4, but we asked her, what do you want to do when you grow up? Do you want to be a scientist like Mummy, or do you want to be a doctor, or do you want to be an engineer, or what do you want to do? And she's like, I want to be a pumpkin. So I think she'll always have a job. but we haven't really thought that far ahead. Like I said, I think everything's going to be affected. I think computer sciences are probably a little bit safer for the intermediate term. I think we'll probably direct her in that direction.
There'll probably still be a need for plumbers.
Halloween will be a bitch for her. Guys, any other comments or questions for Colin?
So, for these deep learning models to work, it requires a lot of data. And in the healthcare system, a lot of data is, the public's data, the patient's data. How does a company like Google and IBM, I guess, monetize things like that, developing these algorithms when in fact it's the public that owns, or technically belongs to the patients?
At the moment, both IBM and Google are giving their software away. So they're not actually charging people to use Oncology Assistant or DeepMind. They have agreements with governments and various private radiology providers and cancer providers to get their data. Because at the end of the day, the company that has the most data is the one that's going to win the AI war. I don't know. So, the NHS has obviously found some way of finding an agreement with the people that's managed to pass through Parliament. With private providers, so Capital Radiology over East have an agreement with Enlytic, which is an Australian AI group, and they get patient consents for all scans to run it through their anonymized data through their deep learning algorithm. There's a radiology group here, I won't mention who, a large radiology group here they run their MRI prostate data through a machine learning algorithm, or they've provided their data to a machine learning company with the patient's consent. So I think for the most part, there are a lot of patients who don't care about certain data. I think with imaging data in particular, I don't think they mind too much. With other, like historical data, past medical history, I think that sort of stuff is going to be a little bit more tenuous.
You have something like this in rapid planning, where you feed the system with data, and through the database the system will do plans for you. This is the future. We haven't commissioned this yet, but we have an option like this.
Rapid plan, that's using a knowledge base. It's using previous plans, isn't it?
We can put our own plans. Yeah, we build our own model, of course. But
well,
it's the same.
It's similar. So
it's similar, yeah.
But so the downside to that is that's a mixed model where you're using data that an expert has volumed or planned, and then you're saying, look, machine, this is good, keep doing things like this. But that may not actually be the best way to do it. But it is a shortcut. When you don't have enough data, it is a shortcut way of getting something in between.
Yeah, let's talk about kind of producing clinically acceptable plans in that way, and then tweaking to get, it's whether people would be happy with clinically acceptable versus
talking about the principle.
It's good.
Anywhere in the public system, an artificial intelligence-based system is accepted and routinely used. Is the FDA or something will come in the part and say that no, it's not a 100% proven system, and then.
So it's being used in the NHS as part of. So the renal unit have completely adopted DeepMind as a routine part of their patient workflow. And the large cancer centres, so MD Anderson in the States and Sloan Kettering, have that as a routine part of their oncology workflow, the Watson Oncology Assistant. So all the data goes through that.
All right, guys. Harry, first of all, just like to thank you very much on behalf of everyone. We had a fantastic, interesting evening. Really appreciate it. We did, on behalf of Roro, got you a small gift in there. Like most things, someone else brought a really nice gift and I've done a terrible job of wrapping it. So I love gift bags. It's just something for you to take away. And I think I'd like to get everyone to join me in thanking you. And do not go home and watch Terminator 2 tonight or The Matrix.